A 16-year-old presents with a painless palpable mass on the dorsal aspect of the foot. I am showing you sagittal T1, sagittal stir, coronal T1, and post-contrast coronal magnetic resonance images. Please describe the findings.
The magnetic resonance images demonstrate a solid, well-defined, smooth, soft tissue mass arising from and closely associated with the extensor tendon sheath. Crucially, the mass displays homogeneous low to intermediate signal on both T1 and stir sequences and shows diffuse, intense enhancement after contrast administration.
What is your primary diagnostic concern?
The findings of a solid tendon sheath mass showing homogeneously low T1 and T2 signal with diffuse enhancement are highly characteristic of a giant cell tumor of the tendon sheath.
How is this tumor classified in relation to pigmented villonodular synovitis?
Giant cell tumor of the tendon sheath represents the localized, extra-articular form of tenosynovial giant cell tumor. Pigmented villonodular synovitis is the diffuse, intra-articular form of the same neoplastic spectrum.
What is the physical explanation for the characteristic low to intermediate signal intensity seen on both T1 and T2 magnetic resonance sequences?
The low T1 and T2 signal is due to the presence of abundant hemosiderin deposition within the tumor, which causes local magnetic field inhomogeneities and T2 star susceptibility effects, alongside dense collagenous tissue.
Where do these tumors most commonly arise in the musculoskeletal system, and what is the second most common site?
They most commonly arise in the digits of the hand, particularly on the volar aspect of the fingers near the interphalangeal joints. The foot is the second most common site of involvement.
What bone complication can occur in up to 20% of cases, and what is its clinical significance?
Adjacent bones can develop smooth, extrinsic pressure erosions. This is clinically significant because residual tumor cells can reside in these cortical recesses, acting as a major risk factor for local recurrence after surgery.
How do you differentiate a giant cell tumor of the tendon sheath from a fibroma of the tendon sheath on magnetic resonance imaging?
While both demonstrate low T1 and T2 signal, a fibroma of the tendon sheath is typically much less vascular and will show little to no contrast enhancement, unlike the diffuse, homogeneous enhancement seen in giant cell tumor of the tendon sheath.
Finally, what are your clinical management recommendations?
I recommend complete surgical excision of the mass. If cortical bone erosion is present, marginal cortical scraping or resection is recommended to ensure complete removal and minimize the 10 to 20% risk of local recurrence.